So guide extensions are important chip accessories. They are essential for any new chip labs. So what are guide extension catheters? There are coaxial mother and child catheters which are employed to facilitate any device delivery like guide wires, balloons or stents. But they can be used in many different complex scenarios. Increasingly the indications are more for guide extension catheters, and they are essential for any chip labs. They are used because guide catheters we cannot push through the coronary because they have fixed primary curves and cannot be safely pushed deep into coronary. So guide extension catheters have softer either PU or a silicone tip and with a flexible shaft so that they can be engaged very deep into distal coronaries. They have been used first in 2010, and since then many firms have come with different sort of guide catheters. The main purpose of using guide catheter extensions, the largest registry is a 20 registry, which came out in 2020, and in that registry, most of the guide extensions were used for abnormal anatomy and also for support, mainly the backup support. About 58% of cases were used for a backup support for delivering either wires or stents. And facilitate stent delivery. In stent delivery, it helped in about 30% of cases. And it is also used for correct coaxial arrangement of guide catheter. So if you don't get a very good coaxiality with guide catheter, you can use a guide extension to further achieve good coaxial with the coronary. And it's also used for diagnostic. It can be used for selective contrast injection. For example, a large dominant LCX, which is abnormally placed in the ostium. So you can get a very good coronary injection. And SVG graft angiograms, even Lima angiograms to evaluate distal native LAD beyond the point of anastomotic site. So we can push the guide extension through the Lima and take a good injection to evaluate more distal coronary. And even post-TAVI coronary PCIs, they are increasingly being used. And it can be used even as a thrombus aspiration catheter. And the presently available guide catheter extension, the first one was GuideLiner, and the 20 registry is mostly done with the GuideLiner V2 catheter. Now we have GuideLiner V3 catheter. It was approved in 2009 and used in 20 registry also. And GuideSila is that one from Boston Scientific. It was approved in 2013. Telescope is from Medtronic, and they got approval in 2019. And there are other catheters like Guideon and Guide Plus 2 from Nipro. The basic difference is that this was the first one, the prototype one, and it's a rapid exchange one, mother and child guide catheter. It's available in 5.5, 6, 7, 8 French, and fits inside a 6, 7, 8 guide catheter. So you can even use a 6F guide catheter for PCI, and it has come for radial procedures. Generally, it's 1 millimeter. The guide extension catheter will be 1 millimeter smaller than the inner diameter of the corresponding guides. Usual working length is 145 centimeter, and there is a 25 centimeters push lumen. That's a pushable one into the coronary. And this has a radiopaque marker 2.7 millimeter from the distal catheter tip. And this is a 20 GuideLiner registry. And hardwares which can be used via 5-in-6 French GuideLiner, which is a workhorse in most cases. All routine guidewires can pass, balloons can pass, OCT catheters can pass, and all coronary stents up to a diameter of 3.5 can pass. 4 millimeter stents, it is difficult to, it cannot be passed through a routine 5-in-6, but 6-in-7 can be used. And which cannot be passed are thrombectomy devices, routine thrombectomy devices. But the thing is, guide extension by itself can be used as a thrombosuction device and in association with a balloon. And some IVUS probes cannot be used. And SKS inflation is not possible. Rotablators are not possible. Intravascular lithotripsy balloons are generally not possible to pass through smaller 5-in-6 GuideLiner. It can go through bigger GuideLiners. And orbital atherectomy balloons and laser catheters. And this is the one from Boston Scientific. It's a rapid exchange mother and child catheter, 6 French, which fits in a 6F guide catheter. It has a bioslide coating. Slight differences are that it is hydrophilic, so it slides easily into the deep coronaries, deeper into coronaries. And the other difference is that the GuideLiners, there is a stainless steel ribbon-like flat material which you push on. Here it's a hypotube. It's a tube-like structure. And otherwise it's pretty similar to the other one. This is a stainless steel collar at the end of near the tip of the catheter, while in guideline it's a all polymer collar. And this is the one from Medtronic. This is a telescope catheter. It has a platinum iridium mark at the tip, just like any others, tapered portion of 10 centimeter. It has a slightly tapered one. So tapered profile is there. So probably it goes more deeper into more distal, smaller coronaries. And it has a nylon-based polymer collar, so it's less traumatic. And the distal marker band, which is 1 millimeter long, which is located 2 millimeter from the distal tree. It's closer. And it has a 3 centimeter long spade shaped at the proximal entry point. And this is the Guideon one. This is from the IMDS, and it is very similar, except that there's a proximal part. The entry of the hardware is easier because its bevel is more straightened. Even in Guide Plus from Nipro, there are two types that they have. The only difference being that Guide Plus 2 ST has 4.7 French end profile, while Guide Plus 2 EL has 5 French end profile. Except that both catheters are same, similar to most other catheters with a hydrophilic coating at the tip. The bevel here is more slanting rather than more curved, so that proximally the most of the hardware delivery is easier. They will not get stuck at this point proximally. That's the advantage. And now something new is available. This is a trap liner, which is nothing but a guide liner V3 plus an additional trapping balloon, which is located just proximal to the tip part. And the advantage of it is that we need not use the standard balloon trapping to exchange things. Once this is there, you can use this balloon, inflate it, and through that you can exchange the microcatheters, wires, etc., without changing the guide extension. So that's the advantage of trap liner. It's called as a trap liner. And benefits of a traditional trapping guide liner is that it allows exchange of microcatheters and guide wires, and it gives good backup support for wire crossing across a CTO if the guide extension is used for a CTO, and facilitates stent delivery and avoids risk of wire escaping. So this was a recent one where they have used, it's a 2021 demonstration of a catheter which is placed, stent delivery done with a jet placed and a parallel balloon inflated to support inside a graft to facilitate stent delivery. And situation where it's not advisable to use guide extension, tortuous celiac vessels, osteal lesions in LM, sharp angulation at the ostium. There it will be not very advisable. There are certain techniques to advance guide catheter advancement. One is the balloon assisted tracking, which is commonly used, where you push a balloon partly outside the guide catheter extension and then push the whole system slowly. This is slightly more traumatic, but balloon is the one which is traumatic. So that helps. And otherwise, you can use the inchworm technique, where you inflate the balloon and slightly, while you deflate the balloon, push the guide extension, give a constant pressure on the guide extension, so that slowly you repeat the same cycle to advance the guide catheter extension. Third is the distal anchor, where you put a balloon parallelly along with the guide extension. You can support the guide extension and anchor it, or inside the guide extension itself, if the balloon is there, you can put it distally and then inflate the balloon, push the guide extension and deflate the balloon once it is in position. Or it can also be used for protecting the stent, to avoid damage of a stent in a difficult vessel, where you do the distal anchoring, insert the guide extension, and use the stent till where you want the stent to be, and pull back the guide extension so that the stent is unsheathed. And application is generally to increase backup, to bypass calcification and tortuosity, to limit contrast in renal failure, and it can be used in CTO-PCA in reverse cast technique, where you can capture using a guide extension, the retrograde wire, and so that it easily need not go to the guide catheter, rather it can be captured in the guide extension. It can also be used as a balloon, with the balloon as a buddy, for thrombus aspiration, used in presence of a previous tabby coronary access, and it's also used to retrieve a stuck burr, and also used in SVG angioplasties. Generally, the complications are coronary dissection. For this, you can avoid a forceful injection. The injection through a guide extension should be about 2 ml per second rather than 5 to 6 ml per second. And another issue is that you can have a loop formation and ischemia. You need to know the coronary ischemic time for each patient. It differs. So, and you can avoid in vessel size less than 2.5 millimeter. And another problem being air embolism. And 10 techniques to minimize the risk of guide catheter related complications are: avoid advancing guide extension against resistance, and avoid in the presence of osteal branch disease, avoid in small vessels, manipulate mother and child well. The guide catheter should be maximum coaxial so that guide extension is also coaxial, and if possible deliver it over a shaft of a coronary balloon, and then injection rate should be low. Y catheter valve should be tight to prevent air embolism, and you should be careful in handling it, because when you inject you should not you should hold the guide extension firmly to prevent it from ejecting into the coronary. And when you take some hardware out of the guide extension, you should be careful that again it should be fixed at that point, otherwise it will cause dissection at the ostium. And try to use a balloon if possible. Thank you.
Thank you, Dr. Praveen. May I have one question? We have, I think, 3 of these are commonly available to us here. If you are to select one in a cath lab of any of the, I know there are subtle differences between these two. Is there any reason to go for one, or is it the operator experience?
I think it's the operator. I think most of the things are, one is we have for guide Scylla, you have 6 French available very commonly. Guideliner 6 French, I'm not very sure whether it's available with us. We have 5 French, and ST5 also 5 French.
On the same topic, most of the industry that makes those 6, 7, 8 French, they're much the same. I usually alternate them all the time. Of course, Telflex has a 5.5 and more importantly 5. Quite commonly, if you do 5 French intervention or even 6, 7 intervention, but this 5 can deliver things more distally. And through the same 5 French, you can do small cutting balloons, small OPNs. Yes, you can do rota through 6 French, guide extension, 125. If it gets stuck, you can take it out and go and block together from all the way from the TUI, but it can be done. Trapliner is very useful device. It's only Telflex has it. And for antegrade cases where you complex, where you anticipate a lot of catheter device exchanges, it's really good. Saves a lot of time. Obviously, you have to bleed back after each trapping, as is normal trapping balloons, and you can do safely ADR with Stingray in 6 French trap line as well. And the more important point is to avoid injections through any guide extension deep in the vessel or in the grafts, because it can cause dramatic complications, especially, for example, if you position your guide extension mid-distal right, do injections there for distal bed, but you'll have pre-dilated the whole tree initially, it can go all the way to aorta. So if you need to do injection, you have to retrieve it and inject only like 1 centimeter in the ostium. Lima, it's another cattle fish, it's very important. If you decide to inject in the lima, again, only through the tip inserted in the lima, but at the same time, guide catheter has to be taken out at least ½ centimeter from the ostium. Otherwise, there is a razor effect possible from the jet between the guide and the guide extension into the ostium of the lima.
Yeah. One occasion you mentioned actually the stuck rotor, we can actually deep into it. Once we had actually stuck balloon, not even rota, stuck balloon, it was not deflating. Actually deep intubation was not possible with the guiding catheter, and this extension catheter helped.
If you look at the 4 guide extension catheter, the first 2, the Guidezilla and Guideliner, both of them, they are the first generation one, and the other 2 can be classified as the second generation. Advantage of telescope is distal braiding is not there. So if you want to do an OCT of the left main ostium or the RC ostium, you could use it. You could keep the disengage the guide catheter, keep the guide extension, the telescope catheter inside the ostium, and then inject so that you will be able to identify the ostium. The light can pass through that so that you can easily identify the ostium. The advantage of Guide Plus from Nipro would be the trackability is extremely good with Nipro. So then deep inside the vessel, getting in over the stent, also getting the Guide Plus would be very easy.
And it's also very atraumatic. Guide
True,
Plus.
very true.
Yeah. So, and regarding sending IVAS, this OptiCross catheter will go through 6 French guide extension.
6 French.
And in fact, in all low contrast PCIs, especially if you are doing in a vessel which is very tortuous, it's often very difficult to send short monorail IVAS catheters into the distal segment of coronary, as well as into the LCX, which is usually, around more, if it is more than 70 degrees band. So in such cases, preemptive guideliner usage to send imaging saves, a lot of contrast. So, and a lot of your time also. So it can be also used in a very, low contrast PCIs in a tortuous vessels and in LCX. Yeah.
Thank you, Dr. Praveen.